that have delayed the start here. We're going to go ahead and just dive in to this session. So I'm Matthew Cavanaugh. I'm the director of the Global Health Policy and Politics Initiative at the O'Neill Institute for National and Global Health Law at Georgetown University. Thank you to IAPAC and the whole team that have put together the excellent pre-conference on the 90-90-90 target setting. There were several fantastic sessions yesterday, including an excellent one with Winnie Byanyima and Jose Zuniga, where they talked about a number of the different key issues that are going on now when it comes to inequality, et cetera. Operator, if it's possible to take off the slides, that would be fantastic, because I'm not sure what's going on there. Perfect, thank you. So what we're here today to talk about is the enabling policy environment. So policy matters. It's an intervention, and we often talk about HIV treatment, we talk about condoms, we talk about prevention programming in a variety of ways. We talk deeply about PrEP programming and how you do it and how you do it well, but we often don't think about policy as an intervention. And this session really is going to think about that, right? The value and the importance of the enabling environment, because we can have sufficient funding, we can have excellent science, we can have caring clinicians, we can have mobilized communities, and we can still fail at many of our targets and many of our goals based on the policy environment. As we look out across what's coming and the goals that were set for 2020, we are not on track. The HIV treatment goals are increasing, but not at the pace that we need them to be. We see deaths from HIV stagnating, right? They've caught, rather than seeing a rapid decline to 500,000 as was required. And HIV infections are not declining anywhere near the rate that we need them to see. It is likely that we're going to miss the targets. And so the question becomes why? And I think our answer in part is that the policy environment explains why. That the limitations when it comes to any number of pieces of what the laws say and the policy pieces say, those actually explain what's happening in countries. And so apologies, I was going to show you a few fun slides. We'll share them another time from a project that'll launch in September called the HIV Policy Lab, that we've been collaborating with a number of the colleagues on here, including with Edwin, who I'll introduce in a moment, to share what does the policy environment look like, and can we take that seriously? But the upshot is we can say, laws and policies touch on any number of things. Which drugs are available for people living with HIV? Do they have the newest medicines or not? Do they have access to differentiated service delivery in various countries, right? Can I get my drugs at home is a question. Can I get my drugs in my community? Can I get my medicines where I need to, and will they come to me? HIV testing is a whole nother set of interventions, right? So we think about, index testing and partner notification. Do they exist? And are they rights-based? Can I get self-testing? And then we can turn to issues of structural laws that we much more think about as laws, right? And chief among them is criminalization and the various forms that criminalization takes. Whether that's the criminalization of HIV, or it's the criminalization of sex work and gay sex and using drugs, a variety of those form part of the policy environment, and they're deeply linked to the other policies, right? If you have differentiated service delivery, but you're criminalizing gay men, you're unlikely to make good progress. If you're not criminalizing gay men and you still don't give people ready access who are newly diagnosed, who have who are asymptomatic, who have not been sick, if you don't make it easy for them to access HIV treatment because you've locked it away, you're also not going to make progress. So part of what we want to talk about in this session is how do we put together the interlocking pieces that look like a good policy environment? Because it's not that we don't know. And so that's where we're going to go today. And so I'm really very, very pleased to get to moderate this session and get to introduce you to two fantastic participants and really leaders in the field. So I'm going to introduce both of the speakers now, and we'll share their slides and their presentations that they've pre-recorded. And then we're going to move into a live Q&A. So folks that are tuning in, please do think about what your questions are. Feel free to send them as we go during the presentations, because then I'll be reading them out during the Q&A when we ask our speakers to stay with us and join us as we think about what the policy environment looks like. So moving next on to kind of who's going to speak here. So Dr. Cherie Kelly, she's the applications team lead at the Burnet Institute in Melbourne, Australia. She's an infectious disease modeler, and she specializes in applied health economics. She has for over 15 years worked with countries across income levels in global regions and a wide variety of national and international organizations, including UNAIDS. And so she's going to speak first. And then you're going to hear from Edwin Bernard. So Edwin is the global coordinator of the HIV Justice Worldwide Coalition and the executive director of the HIV Justice Network. Many of you will know him. He is a journalist who brought us critical information, including about HIV criminalization in his work. Having lived with HIV since 1983, he founded the HIV Justice Network out of a satellite meeting at an IAS conference 10 years ago. So Edwin, congratulations on 10 years of the HIV Justice Network. We use, and I use the publications that they have put out, both in the data work that we do, but also in the activism, right? And it's an incredibly important resource, and that's really, I think, transformed how people think about criminalization. So with that, let me open up to the presentations, and then we'll come back in just a moment, and what we'll do is we'll dig into both the presentations and this broader question. What does a just policy environment look like? How do we think about ending AIDS through the use of policy? And how do we think about what justice looks like for people living with HIV and most impacted communities? So with that, over to you, operator, for the presentations. Thank you.
Today, I'm going to talk about the implications of HIV criminalization, notably its detrimental effects on human rights and public health. And then I'm going to show you how we came up with a solution to mitigate some of these harms. And finally, I'll briefly address the implications for punitive responses to COVID-19. The HIV Justice Network is a global information and advocacy hub for individuals and organizations working to end the inappropriate use of the criminal law to regulate, control, and punish people living with HIV. That's what we mean by HIV criminalization. We also coordinate the HIV Justice Worldwide Coalition, which campaigns to end this HIV criminalization. At the HIV Justice Network, we learned early on that video can convey advocacy messages far more powerfully than the written word. So to begin, the harms. Here's a short clip of a video we made to launch the HIV Justice Worldwide campaign.
HIV criminalization laws are always stigmatizing and in many instances are overly broad. This has the effect of placing people living with HIV at extreme risk of a very broad range of human rights violations.
Well, so many of these investigations and prosecutions are selective and arbitrary, and they often have a disproportionate impact on racial and sexual minorities, trans and gender nonconforming folks, migrants, and certainly women.
Sometimes HIV criminalization can be used to control, to abuse, or to retaliate against a former or current partner living with HIV by threatening to go to the police.
HIV criminalization is horrible public health policy. You can't be prosecuted if you haven't been tested. So it's become take the test and risk arrest.
Not only do a significant number of new infections come from people who are undiagnosed, testing is also the entry point for treatment and care if you're positive, and prevention services including PrEP if you're negative. Patrick O'Byrne is lead author of the 2013 Social Science Review article, HIV Criminal Prosecutions and Public Health, an examination of the empirical research. He's also studied the impact of HIV criminalization on gay men and documented how it has impacted their testing and sexual practices.
So, unsurprisingly, you have lower rates of testing, you have higher numbers of sexual partners, you have more unprotected sexual context. Really compounding this, however, were the qualitative interviews we did. Nobody could make a distinction between the public health department and the police. And this is problematic, right? How can you provide healthcare services when people think that you are a police agency? How do you provide care when people won't access it? Right? So the people who are supposed to be there to do HIV prevention can't. They absolutely cannot, because you can't provide services to people who aren't in clinics. Like, the laws have effectively rendered your HIV prevention health professionals, right, useless.
With the increasing rollout of molecular HIV surveillance and the fact that medical records can always be used as evidence in court, HIV criminalization also seriously impinges on the relationship between people diagnosed with HIV and their healthcare providers. The HIV Justice Network has been undertaking global monitoring of laws and cases for more than a decade. The Global HIV Criminalization Database is a new interactive interface now available on our website. The majority of criminal cases around the world are based on potential or perceived exposure to HIV, and verdicts often fall short of being fair, rational, and just. This is why, for example, we have seen prosecutions for biting, breastfeeding, spitting, and cases like these.
In Canada, a woman living with HIV who had an undetectable viral load was put on trial for aggravated sexual assault for briefly letting a man perform oral sex on her.
In Malawi, a woman living with HIV was prosecuted for breastfeeding.
In Texas, there's a man with HIV who's in prison for 35 years for spitting at a cop.
In the US, a woman living with HIV was raped. She was so afraid of being prosecuted for not disclosing her HIV status to her rapist that she decided not to report it to the police.
Despite global policy guidance to limit HIV criminalization, it was clear to us that too many laws and cases were fundamentally unjust because they didn't reflect up-to-date HIV science. So we conceived of a document that could support expert witnesses and educate lawmakers and criminal justice system actors, partnering with colleagues at IAPAC, IAS, and UNAIDS to make it a reality. 2 years ago, the Expert Consensus Statement on the Science of HIV in the Context of Criminal Law was published in the Journal of the International AIDS Society. Authored by 20 of the most eminent HIV scientific experts, endorsed by another 70 leading scientists around the world, the statement clearly and authoritatively describes current evidence on HIV transmission, treatment effectiveness, and forensic science in a way that's relevant for criminal law contexts. The statement was launched at a press conference during AIDS 2018 and made an immediate impact. More than 50 mainstream media outlets across the world ran the story. These articles finally got the message across that HIV criminalization is both unscientific and poor public health policy. The reason the message was heard clearly and was so widely disseminated was because it was delivered by leading HIV experts from all over the world, rather than by activists like me. We filmed the expert authors meeting in person for the first time at IAS 2017 in Paris.
A statement like this for me is really necessary because we found out that not everyone is very well informed where we are in terms of science.
We thought it important to state those facts, to state what we know from a scientific perspective in order to provide the evidence for the justice system and the legal systems in countries to use it as they wish.
I think we need to bring our science into justice. And we need to be sure that it is understood and that it has the liberating quality that certainly it has had for all of us in the scientific world. It's time for the legal world to understand the current science of HIV.
There is no doubt that this is important knowledge to get out to the broader world. It is our responsibility as people who are immersed in the science to make sure that every sector of the world is aware. And in that way, I believe that people can be treated fairly and equally and justly throughout the world.
My colleague, Sally Cameron, who also coordinated the process of putting the statement together, recently undertook a review, published this week, to examine the impact of the statement since then. To be honest, it's exceeded all of our expectations. Not only has it been used to head off prosecutions and support defense arguments all over the world, it's also been used to strike down Colombia's HIV-specific criminal law and is currently supporting strategic litigation efforts in Kenya, Lesotho, and Uganda. In fact, the statement has successfully shaped law and policy reform in Belarus, Burkina Faso, Canada, the Czech Republic, Morocco, and Zimbabwe. A number of the statement's authors have gone on to provide expert testimony in key court cases, and the New York Times published an influential op-ed piece co-authored by Chris Byra with HIV criminalization survivor Robert Suttle. Of course, it would be naive to pretend that science alone will end the unjust laws, policies, and practices that lead to HIV criminalization, as well as the many other unjust punitive responses to populations disproportionately impacted by HIV. So we need to ensure that social, racial, and economic justice and human rights arguments are heard too. That's more important now than ever, given the pandemic of bad laws, policies, and overly zealous law enforcement that we're seeing as a response to COVID-19. HIV criminalization is often cited as a model for such a draconian and ill-thought-out response. HIV is not a crime, and COVID-19 is not a crime either. That's why the HIV Justice Worldwide Steering Committee published a statement in March about lessons learned from our experiences working to end HIV criminalization. First, criminalization is not an evidence-based response to public health issues and often does far more harm than good. Second, criminalization disproportionately impacts the most marginalized, stigmatized, and the already criminalized people and communities in society. Third, measures that are respectful of human rights and the empowering of communities are more effective than punishment and imprisonment. And fourth, communicable diseases are public health issues, not criminal issues. To conclude, it is more critical than ever to commit to and respect human rights principles, ground public health measures in scientific evidence, and establish partnerships, trust, and cooperation between scientists, law and policymakers, and the most impacted communities.
Thanks for the introduction. It's my pleasure to talk to you about creating enabling environments for optimal HIV responses. Tremendous progress has been made in the HIV response, but why haven't we achieved even higher levels of HIV testing and treatment? For 2018, it was estimated that the gap to reaching the first 90 was 4.3 million people. The gap to reaching the first and second 90s was 7.4 million people, and the gap to reaching all three 90s, 7.7 million. Why haven't we achieved even more reductions in HIV infections and deaths worldwide? In 2018, it was estimated that there was a 16% reduction compared to 2010. This is far from this year's 2020 target of a 75% reduction. Similarly, for HIV-related deaths, a 33% reduction in 2018 compared with 2010, but not halfway towards the 2020 target. This is because of barriers, particularly in certain locations, and particularly among certain populations. So what are some of these barriers? In the Central African Republic, it was said that stigmatizing attitudes and discriminatory behavior and political and humanitarian crisis could explain the low coverage of antiretroviral therapy. In Washington, D.C., stigma and discrimination against the LGBTI community and people living with HIV still creates many issues towards access to HIV services. Here are some strategies towards an enabling environment for HIV. They include a society free of HIV-related stigma and discrimination, gender equality, supportive legal environment and access to justice that you'll hear about after this talk, and synergies in the development sector towards reducing poverty, increasing housing, education, work, and social stability. UNAIDS has put forward 10-10-10 social enabler targets by 2030, and these are that less than 10% of people living with HIV report internalized stigma, less than 10% of women and girls experience intimate partner violence, and less than 10% of countries criminalize sex work, possession of small amount of drugs, same-sex behavior, and HIV transmission, exposure, and non-disclosure, to name a few. Here's an integration structure towards achieving our goals. The HIV goals by 2030 are to achieve 0 new infections, have 0 HIV-related deaths, and this is a 90% reduction from 2010 levels, and 0 discrimination. HIV prevention, care, and treatment must be delivered in a people-centered service fashion that allows participation and inclusion. And this incorporates the 95-95-95 targets and system and service enabler targets. The 10-10-10 social enabler targets are also then incorporated to remove barriers and to help create an enabling environment. And these all must be positioned within the broader framework of the Sustainable Development Goals. How are we going to make further progress in the HIV response? It's not going to be any one intervention. We need multiple interventions in the right combination, at the right scale and level, targeting the right people in the right places. Solutions will be complex and context specific. You can think about it like trying to fill this jar. First, we put in large rocks like treatment, testing, and prevention. Then smaller pebbles like structural interventions for a more enabling environment. And then sand, and that will be things like customized intervention modalities, etc. But putting those in the right combination and in the right scale and the right level will help us make further progress in the HIV response so it's more comprehensive. We need to go beyond what we've done in optimizing HIV investment and use existing evidence on social enablers to inform the right mathematical models. All these things together will help us unblock channels and unlock greater benefits. So what is the impact of social enablers? As we're moving towards high coverage levels of HIV testing and treatment in readily accessible populations in many countries, we know that there are structural barriers to reaching the remaining people living with HIV. There's also growing recognition that interventions with direct impact alone, like testing and treatment, are unlikely to end the HIV epidemic. So how can we model these social enablers? Most studies for modeling so far have focused on interventions with direct impact, like biomedical and behavioral interventions. But modeling studies now need to also consider interventions with indirect impact, like those of structural interventions. How much closer to eliminating HIV can structural interventions take us? Well, we're not sure, because we need to first determine what the best combination, scale, and coverage level of these interventions are towards making a more enabling environment in the HIV response. We need to know which population need these services. What effects are expected? Are we expecting changes in behavior, demand creation, more of it, more use of HIV services? We need to know how much HIV programs or non-HIV program budgets should be invested in structural interventions. How much will they cost? What will be their return on investment? And how to address bottlenecks and barriers limiting the impact. At this point, there may be more questions than answers, but we need to carefully evaluate how we're going to approach this. To know how social enablers should be prioritized. In the 2016 political declaration on HIV and AIDS, member states were encouraged to dedicate maximum available resources to fulfilling the right to health for their populations. This included 6% of HIV financing towards social enablers. But how much are member states really investing on social enablers? It's not known, or it's not very clear, because these expenditures aren't regularly reported, and they should be in reports like the National AIDS Spending Assessment, as well as reporting by funding source. However, the proportion of HIV financing on social enablers has been deemed to be setting specific, so there's little preference to have global normative guidance. So how do we know if social enablers are cost effective in the combination of the rest of the HIV program intervention response? Well, we need to examine the quality of the evidence. No evidence of effectiveness doesn't necessarily mean these interventions are not effective. We need to improve our capacity to gather this evidence. But we do know that enablers will help us to expand HIV services to reach the last mile. That's the last 10 or 5% of people living with HIV and those susceptible, so that we leave no one behind. Enablers can also help us address leakages across the HIV care cascade. So if we look at it in the reverse, what's the cost of inaction around social enablers? Without them, the most vulnerable will not be fully reached with HIV prevention care and treatment services. So we know that investing in social enablers is the right thing to do, but it may actually result in higher returns on investment in the long run. The Global Fund has shown that enabling programs work. There have been proven public health outcomes. These are things like positive effects on people living with HIV who know their status, increased coverage levels of HIV prevention, treatment, and care, as well as improved adherence to these programs. They've shown a model effect on reducing HIV incidence as well, and proven that there have been human rights outcomes through enabling programs to reduce stigma and discrimination and increase legal literacy and access to justice. How do enabling environments fit in the HIV response, and now as part of the response to the COVID-19 pandemic? Sex workers, transgendered people, people who inject drugs, and other populations experience violence and abuse, social and economic insecurities, stigma and discrimination, and these can worsen their risk behaviors, thus increasing their susceptibility to HIV infection. As well, they might be unable to adhere to HIV care and treatment. With the COVID-19 pandemic, these things can actually become worsened. These populations may experience even more social insecurity and stigma, violence, and abuse. And this can then, in fact, worsen their risk behaviors and their ability to adhere to treatment. Sex workers in Kenya have been jailed. And there's one quote whereby it's asked, how do you expect women to adhere to the COVID-19 lockdown measures when they can't feed themselves and their families, and many of them don't even have homes? It's been reported to UNAIDS that people have been selling their antiretroviral medication to feed their families. So in this response to HIV as well as the COVID-19 pandemic, we can embolden and strengthen our response by also incorporating enabling structural interventions that allow enabling environments. This can lessen risk behaviors, improve adherence, and end violence and abuse, end stigma, and social insecurity. But it's going to take a strengthened response. Towards eliminating violence and discrimination amongst sex workers, two models were compared. One from Vancouver, Canada, where sex workers are more likely to also inject drugs, and one from Mombasa, Kenya, where sex workers are more likely to also be at risk for binge drinking. It was found that sex workers who experienced less sexual violence were actually able to advocate and use condoms more. And the elimination of sexual violence alone could avert new infections through immediate and sustained effects on enabling condom use. But there are significant differences in the effectiveness of certain interventions, so it's important to apply context-specific models, as shown here. And lastly, I wanted to end with some success stories. One from South Africa, where part of the hands-off program, police training and community engagement between police and sex workers has shown reduced police harassment and abuse against sex workers. In Ukraine, institutionalization of healthcare worker capacity building and campaigns to reduce stigma and discrimination has led to increased knowledge amongst healthcare workers, and that healthcare workers are 2 to 3 times more likely to refer people to HIV testing. They've developed a legal network that provides services to over 300 people each month, and a human rights union whereby there have been positive law and policy changes. In Nepal, empowerment interventions for key populations have led to decreased stigma and discrimination. So again, social enabling programs have been shown to work. Key messages are that modeling structural interventions is a developing area. Many modeling groups are now beginning to consider these structural interventions, but we need to understand which models can be used and the implication of the findings. Co-benefits should also be considered, and we need to continue to expand the evidence of the impact of structural interventions on HIV. This is our call to action. Thank you.
Hi, everyone, and welcome back. Thank you so much for joining and in on that. We're now really, really glad to have our speakers, both Cherie Kelly and Edwin Bernard, here with us for a live Q&A. And so we're going to just open it up, and all of you can participate by kind of going into the chat. And so if you see the chat icon at the right, then you'll be able to engage. So I want to ask a set of questions that I've got, but we also want to ask everyone who's tuned in. Please go ahead and go to your virtual microphone, right? So I get to be your microphone, it seems. So when we're all at the AIDS conference, we would be lining up right now in the aisle, right, to behind the microphone to ask them. So I instead get to be your virtual microphone. So please go ahead and line up and send your questions through. So I want to start off and thank you both for fantastic presentations, and thanks for being here. And can I hear you both?
Yes, thanks
Great.
so much, Matt.
Thanks so much, Matt.
Okay, good. I have you both. And moderator, I don't know if you can turn off the presentation there. So we've got a number of different kind of questions that I want to run us through, but I want to start with kind of the biggest one, right? Which is, so UNAIDS is right now, and Sherry, you had kind of gone through a number of these points, right? About kind of social enablers. UNAIDS is right now, diving into this question of target setting, right? And it's thinking about what should it do. And we're here at the 90-90-90 targets meeting while UNAIDS is in the middle of doing all of the technical work for target setting that I'm not exactly sure how they're going to pull off in the middle of COVID, right? Because it's very hard to set targets, et cetera. But talk to me about, as you guys think about that process, right, of setting new targets. And I had said at the beginning, and I think, Sherry, you put this on your slides. I had said at the beginning, I don't think we're going to make the targets that were set for 2020 right now, right? Which means we're off track, as you showed, for 2030. We need to figure out how to get back on track. As you think about targets and goals for the coming 5 years, what would you say they should be? And let me start with you, Edwin, to just say, how do we think about kind of where we are on criminalization right now? And, there's the world of where we should be, in which there's no laws out there that have criminalized. But then you've also done great work on thinking about, like, even where there are laws, how do you actually think about how they're enforced, et cetera, et cetera. So have you thought about what a goal is when we're 5 years from now? What should we have achieved if we're going to try to get back on track to hit those 2030 goals?
Thanks, Matt. That's a good question and a big question. In terms of HIV criminalization, of course, the half of the countries that we monitor don't use HIV-specific criminal laws. They're using general laws. And so a lot of the change there has to happen within the court systems and in the application of the law. Policing, of course, is important across all criminalization. So, of course, as you've mentioned, complicating matters, of course, is COVID-19, where we've seen really overly zealous policing and problematic new laws. So before COVID-19, I would say with HIV criminalization, we were moving somewhere. We were seeing laws being repealed, laws being modernized. We were seeing civil society and criminal justice system and parliamentarians working together along with scientists and healthcare workers to try and figure out how to improve the legal environment, particularly for people living with HIV. I have to say, COVID-19 has messed all of that up, and I'm actually quite concerned by to try and figure out what, as you say, what targets could we actually realistically look for in the next 5 years. If we could just even tread water, to be honest, I'd be quite happy. I'm very concerned that punitive approaches are getting more and more popular, particularly with governments not listening to science, despite there being excellent science around HIV, and we're learning more about the science of COVID. Science is really not informing a lot of policy. So I wish I could be more optimistic and say we can set some great optimistic targets, but I'd say if we can just tread water for HIV for 5 years, it might be something we can achieve.
Shereen, let me turn to you on this question of target setting. So you had kind of raised, and I think, as you rightly put, there's kind of more questions than answers out there. And I think that's a fair frame, but I'm going to push you for a minute, right? Which is to say, how should we think about, setting some targets, and where do you see areas where we could set targets that are specific enough? Because I think one of the things we've seen in HIV over and over again is that where there are targets, they do drive action. Not everywhere, not universally, they're not easily done, but setting these targets actually means we within the HIV world are very serious about this, right? It's not, we hope that people will get better. We hope that there will be less infection. We hope that there will be fewer deaths. We hope that. And instead what we try to do is we try to put some focus there. UNAIDS in the new set of targets is going to try to set some targets around the social enablers. Where do you feel like we have enough information where we could actually set some targets? And do you have any in mind that you'd like to particularly see?
Thanks, Matt. It's a very good question and also a challenging question. But we can't track what we don't measure. And so from a lot of these countries, we don't know how much is being spent on social enabling interventions. So that's the first thing, is we need to track how much is actually being spent, how much focus is being put there. As far as setting, targets that we can actually hone in on, I mean, we're working with groups in Eastern Europe and Central Asia, and they're interested in, really identifying things that will take them further in this response. I think the COVID pandemic has brought to life more of the inequalities and, some of the policies that are going to, take us further away from our targets. And so by, bringing these maybe to the forefront, it's something that we can then, advocate even more for in terms of, where we want to be in the future. But certainly, these, decriminalizing, sex work, decriminalizing actions against people living with HIV. I mean, those are very key things that countries need to actually, really strongly think about. And as, Edwin has said, it is something that is, it's the right thing to do. It's the just thing to do. And I think it would take us a lot further in terms of people being able to access services where they're not, feeling afraid to come forward, et cetera. So I think that would be a really key target to identify in these countries. And the other thing is, our group in terms of modeling and other groups in terms of modeling, they look at how to best spend the money. Well, it might not necessarily be cost effective, but that's not necessarily the question we always want to be asking about social enablers, so to keep that in mind. Thanks.
Mm-hmm. No, thanks for that. And I think, I think you're right. And I'll just, take moderator prerogative here to say it'd be really helpful if we actually set some goals around criminal laws, right? It would be really helpful if we would set some of those in there, because I think the model that you laid out is right? That there's HIV infections and deaths over here, there's interventions here, and in between comes these barriers. We know what they are, we've shown them, and yet we're not actually measuring how we're doing on progress there. But that's going to take states agreeing to do so. And so I'm worried about the international structures right now and whether they can pull it off, but boy, would that be helpful. I wonder, so Edwin, I want to come back to you for a second, and I wonder if you could talk to us a little bit about the geographic distribution of HIV criminalization. I know everyone should go check out your reports. It's all very clear there. But as you think about criminalization, and especially how HIV criminalization matches up with other types of criminalization, right? So I think about the criminalization of gay sex or the criminalization of sex work and drug use. To what degree is kind of HIV criminalization, does it kind of match? Do we see similar regimes? Is it that countries are overall kind of good or bad on those things together? Or is HIV criminalization actually distinct from those for some reason? And if so, how come?
Excellent question, Matt. And the answer is yes to both. In a number of regions, it's pretty much a surrogate marker for how current and past regimes have treated all marginalized people. So, for example, in Eastern Europe and Central Asia, where we see the highest number of HIV criminalization cases, of course, many other key populations are criminalized. And in some parts of Central Asia, sex outside of marriage, for example, on top of all the other key population issues, is also criminalized. So, and similar to, but in Middle East and North Africa, where we're aware there are many punitive policies for key populations, we don't see very many HIV criminalization laws and actually fewer cases. So there's a mismatch there. Across sub-Saharan Africa, there are many HIV criminalization laws. Many of them were passed as part of omnibus HIV laws, but few countries actually appear to have implemented them. But where they have, it tends to be women who are the first in their status to get prosecuted. In North America, where there are apparently fewer punitive responses to key populations, HIV criminalization is actually a major issue across all of the United States and in Canada. And in Latin America and the Caribbean, we see fewer HIV criminalization laws and very rare prosecutions, but of course, in the Caribbean, many punitive responses to key populations. In Latin America, slightly fewer, but still some. So it's not clear. HIV criminalization is often seen as the ultimate manifestation of HIV-related stigma if it's enshrined in policy, but it's not always a surrogate marker to how countries, governments, societies think about the broader HIV response and punitive responses.
You know, I think it's really interesting and really important, right? Because part of what I think, you know, one of the ways that we often think about these things, I think in global spaces, is that the conversation is that there are some governments that prefer a punitive approach. There are some governments that are especially conservative, that they then, you know, enact certain laws or enforce them in certain ways. And I think it's actually very important to note, as you're saying, right, that these two things don't align, right? That there's actually a lot of work to be done in places that consider themselves to have welcoming environments on HIV criminalization. And I think that that's actually different than the way it's often talked about, right? It's like there are those governments over there, et cetera. And so an inward-looking reality, I'm sitting here in Washington, D.C., right? We've got a lot of work to do here in the United States. It's really important to kind of to make complex our understanding of those policy environments. No, that's really helpful. So Sherry, let me turn to you for a second and say, and sorry if this is an unfair question, right? But what do we know about the degree to which policies actually matter for things like HIV infection, right? And so I know that there's been some good papers out there on a kind of handful of the policies that you're talking about, but talk us through. I mean, as you said, we can't, we can't, study what we don't measure, but some of these pieces we do, right? And so to what degree is there kind of evidence behind certain of the, especially law and policy interventions that we're talking about here? And I'm, maybe we'll stay on the criminalization piece. I'd love for you to talk about that, but if you've got other ones to throw in there, that's great. But to what degree do we have evidence and where do we not have evidence? And we have to be relatively quick, but go ahead.
Thanks, Matt. So in terms of policy, certain countries have mapped over time, when a policy came into place, and then, you can look at what happened to the trajectory of incidence and mortality for HIV. And you can sometimes see, a market decline or at least some change. We worked with certain countries that have, had laws, overturned, like, Botswana in the last, 2019, as well as they actually opened up treatment services to non-citizens who have been living long-term in the country. So that's clearly another enabling environment. And just from that, we've been modeling, what the effect will be on, increased coverage and treatment, which will have an impact on, lessening the, deaths from HIV/AIDS and as well as infections. So while it's too early to say in that country, we would project that would have an impact. And so we can see that these things, in terms of increasing coverage, even in the next year, when people don't have the fear of, accessing these services, it does make a difference. And so if we can pinpoint when those policies have been put in place, we can use it as a success case to show other countries, well, if you actually focus on these items, then you can see, increased, demand for your services and increased success. I hope that's enough of an example there. There are definitely others.
Great. No, that's really helpful. All right, we're gonna have to wrap up in just a few minutes, but let me just read one question, right, that's come in, and we've got a few, but we're not going to get to them all, so I apologize. So what efforts are being put in place to take advantage of COVID-19 to the extent that to HIV, sorry, let me get control of this question. Given the resources available. So look, I think what the question the person's asking here is, and apologies if I'm butchering your question, COVID-19 is happening. It is, as you said, I think it was Sherry, it is exposing the inequalities that exist. They are very, very clear. And, you know, sometimes what has happened in HIV is that we've failed to see the inequalities recently because we saw them early on, right? But then as, you know, as wealthy people or people in capitals, you know, have gotten access, we've disappeared much of the inequality that exists. To what degree does COVID, do you think, represent an opportunity amidst all of the pain that it's bringing to actually get to some of these social drivers, since they are similar across COVID and HIV? And so if I can go to each of you for just a minute, and then we'll move toward wrapping. Thanks. Edwin, do you want to kick off?
Yeah, sure. So obviously, if I were to think that the glass were half full around HIV criminalization, I think that pretty much everyone in the world at every level has experienced some kind of limitation to their rights in the past few months, and understand just how, and may now have a better idea of how problematic it can be when you are being told by your government to do something that you don't feel like you really want to do, or that it impacts your life in some way. And so perhaps this is an opportunity to open up people's eyes to much broader inequalities. Of course, the fault lines have really been exposed, and of course the rise again of the Black Lives Matter movement has really highlighted the problem of really overzealous policing. So perhaps this is an opportunity to highlight how punitive laws and policies related to pandemics, HIV being similar to COVID-19 in that respect as a pandemic, and how people might understand, including policymakers, but also the public, the general public, who obviously need to understand where parliamentarians are making laws to actually say enough is enough. And, you know, we do not want criminalization. We do not want punitive responses, because we can now see just how harmful they are.
And Sherry, I am deeply sorry, but I've just gotten the message that we have to hang up, or they're going to hang up on us apparently. So I deeply apologize for not getting to you on this question, but thank you guys both, Edwin, Sherry. This has been fantastic. I really appreciate your time and your effort. Apologies for our technical glitches that had us start a little bit late. And I'm not sure if we're being seen by the next participants, but if we are, apologies to everyone else who is starting a little bit late because of our technical glitches. May you have a glitch-free piece going forward. One of the critical things as we think about ending this session is we have to think in the next coming period, how do we take advantage of the environment we're in, deal with COVID and the negative impacts that it's having, and 3, really be serious about the law, policy, and structural barriers that are getting in the way of right now. Because if we go another 5 years from now and we reset some nice new targets and miss them completely again, it's, I think, our last chance to actually succeed in this way, and we will not do it without addressing these structural barriers. So as we go on to our next session, I wish you all the very best, and really appreciate Edwin and Sherry for coming on. Thanks, everyone.
Thank you.
Thank you.